Okay, moving on now to the head and concussions. Now, even though this isn't one specific chapter in the book, there's entire courses that could be formed on the head and concussions. So I think it's really important that we spend some time on this, even though not all the material for this unit is in your textbook. There are some supplements on Canvas, specifically the SCAT-3, SCAT-5, and some other handouts that will help lead us into the lab that we'll do in class for concussion and concussion testing. So jumping right in. What is a concussion? Well, depending on where you look or who you ask, some of those definitions might have a little bit of variability, but we do know that concussion is translated from the Latin that means to shake violently. So there's a Vine video that you could click to see the animation, but basically the brain is moving within the skull. So even though there is fluid surrounding the brain within the skull, it still has the ability to move even just slightly. So a concussion happens essentially whenever the brain smashes into the skull, regardless of the side, and can cause injury. So it's essentially a bruise to the brain. Now, with any type of head injuries, there are different scales to categorize the severity of this. If we're looking at some medical terminology, concussions will be classified as MTBIs, or mild traumatic brain injury. Now, no brain injury is necessarily mild, right? We don't want to ever injure our brain, but concussions more on that mild scale, while when we're talking about traumatic brain injuries, this would be something that results in a lot more lifelong issues from. So if someone completely loses their ability to speak or process or find words or even control some of their own body motions and things like that, that would be more of that traumatic brain injury. So concussions, MTBI, mild traumatic brain injury. So when it comes to prevention, there's a lot of things that we can do, anywhere from equipment to strengthening our neck muscles to anywhere in between, proper tackling form, things like that. But we definitely still know that injury is a part of sports, no matter what type of prevention mechanisms we throw into it. Especially because you only have one brain and that's all you've got for your entire life. It's especially important that we try to especially important that we try to prevent injury as much as possible. Now, there's also some stigma sometimes surrounding concussions, brain injuries, and the like, just because a lot of the symptoms that people experience sometimes will be cognitive in nature. So the ability of the brain to actually process thought and things like that. Sometimes people have a lot of emotional extremes anytime they suffer a head or a brain injury. And sometimes, again, it's just embarrassing to talk about. A lot of our athletes very highly driven, very competitive. So if there's a chance that they may have to sit out for a game or a few games just because of concussions, oftentimes they might feel a little bit of internal pressure to not report those signs and symptoms. And that can actually lead to life-threatening conditions that we'll talk about here a little bit later. It's not something that you get your bell rung, you're seeing stars, you're just a little shaken up. No, these are brain injuries. So we definitely need to be serious about them and not just try to shake it off. So when we're looking at some of the structural components, you're not going to be responsible to know the different bones of the skull, but the skull is made of several different bones here. And instead of calling these joints where those bones call together, they're called sutures. So as an infant, whenever you're born, these sutures or these joints of the skull won't be completely formed yet. There are soft spots within the head, and that's also designed to help that infant move through the birth canal. If that skull was completely rigid and completely formed, it would be a lot more difficult. So as we go through puberty and adolescence and we still see growth spurts and things like that, we'll also have a lot more hardening of these sutures or those joints essentially of that skull itself. Now, the skull is one of the few bones in the body that can have depression fractures, where you basically get hit and that whole skull starts to kind of sink in. And that's because as collectively, when these come together, it'll basically form a sphere with some hollow on the inside. So it can have depression fractures. When we're thinking about helmets or other protective equipment, they're not so much intended to prevent concussions, but to prevent skull fractures. Now, if we're looking at the different layers and what's deep to that skull, we have what are called meninges. So if you've heard about someone getting meningitis, we know it's an inflammatory condition, anything that ends in itis, of the meninges here. So those layers that are covering the brain, between the brain and the skull, are going to become inflamed. Now, there are three different layers of these meninges. So the outermost one is the dura mater. Dura translates to tough mother, so it is the thickest, toughest, outermost meninge or layer covering that brain. Deep to that, we have the arachnoid mater. Arachnoid, if you have arachnophobia, you are afraid of spiders. This is translates to like a spider web type shape. So not necessarily a solid layer, but more like a web type layer. And it's going to connect again that dura mater to the meninge again below that arachnoid mater, which would be the pia mater. Pia translates to the Latin for delicate. So a very delicate layer, a more spiderweb type layer, and then a tough, thicker layer. That's all that outer covering of the brain between the brain itself and the skull. Now, if we look at some terminology, again, we have the sub, meaning below, dura. So the subdural space, or the space deep to the dura before that in the arachnoid. And then we have the subarachnoid space, so the space that is just deep to that arachnoid, between that arachnoid mater and the pia mater. This is important when we talk about locations of bleeding on the brain. If someone has a subdural bleed versus a subarachnoid bleed, or an epidural bleed above that dural sheath, it'll just give us the location that that bleeding is occurring. We'll jump into that a little bit later. So assessment of head injuries. Anytime we're suspecting that someone has a head injury or a spinal injury, we know we have to use a lot of caution, just because even tiny, small, deliberate motions could still make that injury a lot worse. Now, not to the extent that the initial trauma had caused, but we're not going to definitely try to pull someone up off the field if we suspect that they might have a head injury, because again, any type of motion could make that a little bit worse. So considering concussions being brain injuries, and how the brain and the spinal cord, obviously connected, go hand in hand, even if we're thinking it is a concussion, we still need to make sure that a cervical spine injury is not present. So if you watch medical dramas, they put someone in a cervical collar and then send them to the hospital. They'll get a CT scan to clear the spine. That's just ensuring that there's no cervical spine damage. At that point, it would become more safe to allow for cervical or neck motion. But we're going to use as much caution as possible, just because until it's ruled out, it's definitely something that might be present. So use as much caution as possible. From a coaching standpoint, this is also going to usually lead to just leaving that athlete where they are until higher trained personnel are present. If someone loses consciousness on the field, or they're just talking crazy, or they seem really disoriented and just not there, we're going to shut them down from all activity, get EMS there, get an athletic trainer, a team physician, someone like that present to evaluate this condition, just because how they present now might even be completely different from how they present 15, even 20 minutes later. So important history, observation, palpation, special test. Again, it's the same 20 questions that we typically play as it relates to history questions. But when we're thinking about loss of consciousness and amnesia and things like that, it's important to get an understanding to find out mentally where that athlete is. Do they know what happened? If they don't know what happened, was it before or after the hit that they're having trouble remembering what's going on? If they can't remember from that injury to the past, they might be experiencing retrograde amnesia, versus from that injury to the present, anterograde amnesia. So at what point are they having recall and memory issues? Do they have pain in their head? Does their neck hurt? Do they have full feeling in their extremities? Does one side sensation feel like the other if you were to touch them? Get an understanding of, are they able to process things? So asking them just very simple questions. Hey, what's your jersey number? Hey, who did we play last week? What's today's date? Give me an approximate time. Is it 7 p.m., 7 a.m.? Where are they mentally in thinking that the brain is able to function cognitively, or be able to think through different situations? Observations. Now, we can't, again, directly observe what's going on and seeing all the wheels move within the brain, but we're able to observe for, do they appear disoriented as far as looking into their eyes? Are they just kind of confused? Are they able to look and and actually sync up with what you're trying to ask, or are they just kind of out of it, staring around? When they speak, are they able to elaborate when they do that, or are they kind of just trying to answer the questions at a bare minimum? Are they having slurred speech? Do they have difficulty now informing their words or even finding their words? Is there a big delay? You ask them a question and they take, 3 to 5 seconds to be able to find the words to answer that question. As far as movement, do they have full motion one side compared to the other, or are they just kind of, spaghetti limbs? They're not able to really control much of their motor responses. Again, there are several different things that we're going to look for on an observation standpoint. If they did lose consciousness, that would be something to definitely note how long they were out, but someone doesn't necessarily need to lose consciousness for them to have a diagnosis of a concussion or an MTBI. Is there any bleeding? So looking around the skull, especially on the face will bleed a lot. So if they do have any type of bleeding, they probably, again, will not bleed to death from that. It's just a lot of capillaries, but because the face is so vascular, it will bleed a lot. So still try to get control of that scene, glove up, stop that bleeding, but then also taking a look at that blood itself, and look a little bit at the color of it and what's called the viscosity or the thickness of it. We'll talk here in a second about cerebrospinal fluid, or the actual fluid around the brain within the skull. If that comes out of the skull, obviously it indicates a skull fracture, right? All that fluid should always stay in the brain, or I guess in the skull surrounding the brain or surrounding the spinal cord. So if this comes out, that's going to tell us something serious is going on, more than just the bleeding, right? So this should never leave the body at all. Since it does have a different viscosity from the blood, if we collect that blood with a piece of gauze and then we look at it later, it will have a positive, what's called halo sign, or that cerebrospinal fluid, because of the different viscosity or thickness, heaviness of it, it will actually move to the perimeter. So it'll look like a gold halo, like angel's halo around that blood. That's definitely going to be sign that we need to refer them immediately. So palpation, again, just kind of feeling around on the neck, on the skull. Is there any point tenderness? Do we feel any deformity? Again, being completely nice and smooth is something that we should feel, but if we feel a big divot here, again, that could show us that we have a depression fracture. As far as special tests, a lot of the tests here are, again, just trying to figure out the severity of these symptoms. So from a neurologic standpoint, we're testing what's called the cranial nerves, or how those nerves within the brain itself are going to function. A lot of those nerves are responsible for eye tracking, vision, so just being able to see, taste, tongue movement, a lot of your facial movements, so raising your eyebrows, blowing out your cheeks, sticking out your tongue, move it side to side, things like that we'll talk about a little bit later. As far as eye function, again, these are directly tied to some of those cranial nerves. And we're looking at the pupils, or that black portion of the eye. Are they abnormally large or abnormally small? That would be dilated if they're very large. Are they irregular in nature? Are they completely round, or does it seem to be torn at all and kind of moving outside of that nice round border? We also want to make sure that those pupils are able to accommodate to light. So if I take a light and I shine it in their eyes, the pupil's job is going to be to restrict or constrict, to delay light from entering those nerves in the back of the eye. So if the pupil constricts when I put light over it, that's normal. But after I move that light away, it should return to its normal size. So just a left-right, does that one do the same thing that this one does? We're also looking for eye tracking. So when we have them follow an object, that pursuit of motion is nice and smooth. It's not real jumpy. There's another term that comes into play here called nystagmus. Now, nystagmus is going to be like, it translates to dancing pupils. So this is going to be one of those things that you might see in a field sobriety test. They'll have you kind of smooth pursuits tracking as they have you follow their finger, a pen, something very small. They'll kind of move it around your head, and they're looking for that nystagmus. So especially at those end ranges, if you're looking kind of in that end field here, not directly in front of you, but at those ends, the eyes will kind of start to twitch back and forth. That's that nystagmus. So again, that's not something that we can directly control, but something that we can easily assess for. So when we think about a lot of those DUI type tests, we're also seeing some delays in the brain function that you would also have if you did have a concussion. So a lot of these tests might be very similar to what you would see on the side of the road if you did have to take a sobriety test. Balance test, again, very similar to some of those sobriety tests that you might have. There's what's called a Romberg test. So basically just a heel toe walk. If these lights on. Basically just a heel toe walk. And then even from there, we can go finger to nose, seeing if they can follow directions, and then just their own proprioception, their body's ability to know where it is and be able to move and function properly. A lot of coordination tests, and then what's called a BEST test. That will actually be one of the tests that we perform in class when we do our concussion screening test. There's also what's called a SCAT test. It stands for Sport Concussion Assessment Tool. All the neuroscience people in the world will meet at a convention every year, and they make sure that the tests that are being administered sideline, especially in athletic situations, are sensitive enough to pick up any delays of cognitive function, but also still accepted by the literature as being relevant. So the SCAT is a whole packet of specific little tests. So it might have a portion of the Romberg test on it. It'll have a portion of neck range of motion and neck tenderness. It'll have coordination tests. It'll have memory, delayed recall, things like that. But it's several tests that are all developed into one. We are on version 6 of the SCAT right now. And there are different versions of it just based on the year that it was publicized. So obviously SCAT 3 came before SCAT 4, came before SCAT 5, but each year they just kind of take another look at these tests and make sure that it's still good enough for several different levels of sport. So this is something that the NCAA uses, the NFL, the NHL, FIFA, and you'll see all those logos at the top of that SCAT packet. Cognitive test, again, being able to really think through what's going on. There's several different ways to do this, and these can be done either on the field or off the field, and actually should be done both situations. Some are faster than others. So the months of the year in reverse order without, writing them down or using your fingers, anything like that, being able to think through a series of the months, something that we should all be able to do. Counting backwards, again, another field sobriety test. They might say count backwards from 87 until 73. So you have to think, well, I'm not starting at 100 here. If I'm at 87, then comes 86, and then knowing when to start and stop. There's also what's called serial sevens, which personally I find very difficult with no brain trauma, counting backwards in series of sevens. So starting at, let's say, 100, minus 7 would be 93, minus 7 would be, and so on and so forth, which especially if you do have a concussion, can be more difficult, but even for the healthy people can also be a little bit challenging. Again, just recent memory type stuff. Hey, what did you have for breakfast this morning? I'm going to give you these 3 words to remember. I want you to repeat them back to me. And you might not tell them 15, 20 minutes later. I'm going to ask you those same words again. If you do tell them, then they're obviously trying to focus on remembering them. But if you don't tell them, it just kind of helps to assess what's just in their mind without being prompted so much. When it comes to recent memory type stuff, where it can get difficult is that you also need to know the answers to those questions. So if I said, who did we play last week? And you say Missouri Western, well, if I don't know if that's true or not, I'm not really assessing what I need to, right? Same with breakfast this morning. If you said I had a granola bar and a banana, is that true, or did you just make that up just to have it as an answer to the question? So you also need to be able to know the answers to those questions as well. There's, again, a lot of neuropsych assessments. SAC, the standardized assessment of concussion, again, a specific portion of tests that will also be in that SCAT packet. Sometimes these neuropsych assessments can also be computer-based. So something that we do here on campus is the IMPACT test. It stands for immediate post-concussion assessment tool. Yes. And how it works is I've got some pictures later on, but it might have different shapes, and it'll say, is this the same shape that you saw before? There are some different things that the computer will automatically assess. So processing speeds can be something, the ability to follow directions, different things like that. So it's not like, oh, you got an 80%, you don't have a concussion, right? There will be some baseline information that it collects. So usually at the beginning of the season, and then after that injury itself. So we can compare kind of where you score before injury, after injury, and compare those and see how much the deficit exists. Where it can get complicated sometimes is that some of the athletes will say, well, if the impact test is something that's going to help me to get back to play after being injured, I'll just intentionally sandbag it or intentionally do terrible on my baseline test. So later on, when I do have a concussion and I also do terrible, those numbers will be fairly equal and I'll be able to return to play. Well, a lot of these computerized systems have features embedded in them to where if it can pick up on the fact that you're intentionally trying to fail these tests, it just shuts down and makes you restart. There's also some information about the age of the athlete that's taking this test and some information about the direction. So if you're not reading the directions and you just kind of click through, you can't later on say, hey, what am I supposed to do in this section? Well, that would be having to repeat the directions, which might show that, again, you have some memory issues. So you also have to make sure that your athletes are taking this seriously whenever they do start these exams, just because there shouldn't be an opportunity for them to ask a lot of questions along the way. So here's again, immediate post-concussion assessment and cognitive testing. That's that acronym. So again, several different things that it measures. This is something that several of the schools do have. ESU has a license to be able to do this on our higher risk sports. So football, I believe basketball takes the impact test, and women's soccer. But at some schools, again, it could be every athlete that takes this. In some high school settings, they might even have just every student take this when they have their free physicals. It just kind of depends on the licensing of it. So the way that this works is that it might be free for the first 100 athletes, but then after that, there's an additional cost. So the school might have to choose who they test and who might be more high risk compared to others. Some of it might also have to do with the preference of the team physician. So if you have a doc that really likes the impact test, they might want everyone to take it. Whereas if you have maybe some more old school clinicians where they have a pretty good feeling that they can make accurate diagnosis and return to play decisions without this test, they might not see as much value in it. So here's one of those screenshots again from this impact test. They'll show you a shape and they'll ask you, is this one of the shapes that you saw earlier? So without skewing the size of it, without rotating it, yes, no, is this something that you saw? And again, it will develop a score at the end and then also kind of show you some data for several different points throughout. Now, looking at this SCAT test, again, this is going to be that whole packet of several different things, again, revised annually by a lot of the leaders in the field. The ones that we will use will, again, have 8 sections, and then there's also some information to parents, information to athletes, to coaches, even some pocket cards. So what's a red flag? What do we look for? Just sideline. We're not expecting every single coach, every single athlete, every single parent to know all of this just right off the top of your head. You're not going to necessarily have the ability to even diagnose a concussion, but in scary situations, especially emergency brain injury situations like concussions, you might just forget all the training that you've had. So if you have a real quick, just pocket reference, hey, these are the scariest things to look out for. This is the stepwise procedure of what you need to do if an athlete does sustain a very serious blow to the head. It's only going to be helpful. So this SCAT test, again, breaking it down section by section. The first section is going to be what's called the GCS, or the Glasgow Coma Scale. Now, this is something that is used by a lot of emergency room physicians, EMS providers. It's comprised of 3 different sections, and there's a score for eye-opening response, verbal response, and motor response. So EMTs, paramedics might be able to look at someone and say, oh, they have a GCS of 12. Right? You might see that in some medical dramas. Now, this is something that athletic trainers maybe not be using as much, just because it's harder to just mentally memorize some of these numbers and kind of know where that athlete is. We'll definitely have a better idea of their level of consciousness by using different scales. So the AVPU scale, alert, verbal, pain, unresponsive, and there are several other scales, ACDU scales, and some other things just to determine, again, their level of consciousness, if they're deteriorating or getting worse over time, or if they're kind of getting better. So the way the AVPU scale works, alert, verbal, painful, unresponsive, again, it's just looking at how responsive that athlete or that patient is to different types of stimuli. So if I say, hey, Jackson, and he turns around, right, he's alert, he's walking, talking, everything seems to be fine. If he turns around only whenever I call for him, right, he's alert to a verbal stimulus. So he's not just normal walking, talking. I have to, again, try to get his attention somehow. Responding to that verbal stimulus would put him in that V zone. If, again, not walking, talking, seeming fine, not alert to a verbal stimulus, I say, hey, Jackson, hey, are you okay? And he doesn't turn around. Now I elicit a painful stimulus. It's not if they're already in pain, I actually cause pain to that patient. And as far as how I'm doing that, again, there are several approved methods. I'm not going to just punch him in the face and see if he becomes alert, right? That's definitely dangerous. But some things that I can do is just to pinch on the nail bed, right? So even if you are trying to fake someone out, if you just pinch straight down on that nail bed, that'll be painful. So they might just kind of come to whenever you cause that painful stimulus. Another one seen in a lot of ER dramas or medical shows is what's called a sternal rub. So your sternum being your breastbone, if you take kind of the knuckles of your hand and you just grind in that sternum, again, going to be very painful for someone. So if they're trying to fake you out, if you put that sternal rub, they might kind of come to. At that point, they would be alert to a painful stimulus. So if they're not normally alert, they're not alert to a verbal stimulus, they're not alert to a painful stimulus. At that point, they are deemed unresponsive by that AVPU scale. The GCS, again, a scale of 15 based on 3 different things. The lower the score, the worse off that person is. Part 2, again, of this SCAT packet is what's going to be called a MADIC score. So a MADIC score will help orient someone to a person, time, or place. So again, when you're asking these questions, you also have to know the answers to these. Where it can get confusing or difficult, especially for healthy athletes, is anytime, think like high school travel, summer AAU type stuff, showcase, where you're in, let's say, a certain town, but you're bouncing back and forth between several different facilities throughout the day. Plus, you probably weren't the one to actually drive there, so you may not know the name of the facility itself. So let's say that we had a showcase here in Emporia, and we were using facilities at Emporia High School, Emporia Middle School, ESU, the Student Rec Center, and White Auditorium, right? If you're just between all those facilities throughout the day, if you're playing 3 games a day throughout the course of the weekend, and I say, hey, what facility are you at right now? You genuinely might not know the answer, even though you don't have any cognitive deficits, right? So just kind of take that with a grain of salt when you're asking those questions. Some other things we might ask them, what half is it now? That's necessarily without looking at the scoreboard or the play clock, anything like that. Just kind of figuring out if they can process time. Who scored last match? What team did we play last week? Did your team win the last game? Again, if you don't know the answers to those questions, it's not going to be very helpful to ask. There was a situation where, again, it was like a summer travel ball situation. And I asked the girl, hey, what's your jersey number? Right? And she said, let's say 25, but she was wearing jersey number 50. And I thought, uh-oh, like she's so confident in her answer, what could be going on? Well, her teammate gave me a little bit more information earlier in a different game. She'd got a bloody nose. So even though she typically wears jersey number 25, she was currently wearing 50, right? But only because she got blood on her jersey. If you say, hey, what's your head coach's name? Well, I don't know that answer. So you'd have to verify those results with somebody that does know them. Looking at part 3 here, it's symptom evaluation. So there are, on this list, it looks like 22 different symptoms. But again, this isn't all the symptoms that someone might experience when they have a concussion. Again, they might be more physical in nature or more cognitive. So I can't necessarily see someone having difficulty remembering, difficulty concentrating, a lot of sensitivity to light and sound, other than, they might be shielding themselves, things like that. We also have to think that these are self-reported. So if I say, hey, how's your vision? How's your dizziness today? And they say, oh, I'm perfectly fine. If they're lying, I don't really have a lot of great information to fall back on. So when you are getting symptoms, just make sure your athlete knows it's okay to be honest. I need you to be honest, right? Sometimes they might lie about their symptoms, or let's say they have a symptom score of 80 today, and then when we check in tomorrow, I am symptom free. Well, I know you're lying to me, right? So this isn't going to get you back to play sooner, right? We need to know how these symptoms are changing, especially over time, and how this affects the return to play process. So we need to encourage everybody to take these things seriously. And it really comes down to knowing your athletes, who's going to try to game the system versus who's going to be really honest with you. And you kind of need to scare them, right? So later on, we'll talk about something called post-concussion syndrome, which can be a fatal condition if someone returns to play too early after having a concussive blow. So this is really serious. It's not just playing 20 questions just so I know, right? This definitely has some effects a little bit later on. So we need them to be completely honest. So again, it is self-reported, but we would just go through the list every single day of these symptoms. So not only initially, but then every morning thereafter, they would, or every day, just whenever, they would check back in with the medical staff and we would get another symptom evaluation. This is going to be helpful to do all on that same sheet, just so we can compare today versus yesterday versus the next day, right? If your headache has only gotten worse, but your overall symptoms have decreased, that's going to be something to really note. So there's an app version for this, but honestly, I'm not a big fan of the app just because it will just send you a symptom score, but not really show what has increased or decreased. So let's say if I rated my headache the first day as a 1, being pretty mild, but I also had 10 other symptoms, and then on day 3, I had no other symptoms, but my headache now turned to a 6 or a severe, it may not really show that other than, hey, you have a decrease in symptoms. That's usually a good thing, right? So if you do it on paper, you can circle in different colors every day and then just kind of make a little note of what means what, so you can see how these symptoms have gotten better or worse over time. Part 4, this is our cognitive assessment. So really trying to use your brain and think through what's going on. It does take some concentration, but just like all these other tests, it also takes a little bit of skill from the clinician themselves in how they're presenting these questions. So orientation to person, time, and place, again, that's our SAC testing, or standardized assessment of concussion. That's one of those things built into the SCAT. But then we're looking at immediate memory and then some concentration. So this packet lists a couple different word groups. It looks like 4 on this slide that it lists 2-syllable, completely unrelated words. So the first list here, elbow, apple, carpet, saddle, bubble, right, have nothing to do with each other. If I were to have to make my own word list and I say schoolhouse, backpack, stapler, classroom, right, those are all school related things. Or if I say puppy, kitten, iguana, right? Those are all animals, right? So these need to be completely random words. So if you are using this SCAT packet, you have a vetted list of words. It also relies on you enunciating and clearly pronouncing these words when you say them to the athlete. Again, they're not seeing them on paper, they're only hearing you say them. I was part of a study through the psych department at ESU, and the word list that they were using was a little outdated. One of the words on the list was cistern, which I still don't completely understand, something to do with a well, but I heard sister, like not your brother, but your sister. So when I'm repeating these words back, I said sister and got it wrong, even though I repeated back what I thought that I heard, right? So if you are making your own word list, make sure they're kind of up-to-date-ish words, just so that athlete has a better idea of what they're actually trying to pronounce back. Some other rules with this is that they need to be 2 syllables, right? So if we were to try to clap those words, we would have 2 syllables. We don't want to choose words that have several syllables here, like automatopoeia, right? That's way too many syllables. It's going to be so difficult to remember several different words that have several syllables. 2 syllables, exactly where we need to go. We also don't want them to rhyme, right? So if I say book, took, look, right? That's too easy. We need to make sure that they are pretty different. We also want to avoid proper nouns. So names, cities, things like that. So just avoid those because again, they're a little bit too specific. Keep those categories very broad and have just completely unrelated 2-syllable, not proper noun words. Moving on to that digits backwards section. Here we would have numbers 0 through 9, so single digit numbers. You would have several different strings of numbers having one more digit on each consecutive list. You would read it forwards and they would repeat it backwards. So in that case, 1, 2, 3 would become 3, 2, 1. In keeping those numbers single digit, we avoid things like 27, 62, 79, right? Just going with single digit numbers. We also want to make sure that they are also unrelated. So I don't want to go in any type of order. We definitely don't want to go 4, 5, 6, too easy to remember. 2, 4, 6, again, even numbers. 3, 6, 9, not doing that. Or any numbers that are significant. So I would want to avoid 66801 here in Emporia. Well, that's our zip code, right? You also want to avoid phone numbers or anything that also means something else. It's not really testing their ability to remember the sequence of it if it's something that's already meaningful to them. So pretty easy to make your own word or digits list as long as you're following those specific rules. Part 5, neck range of motion. Now in the SCAT 6, I believe this is moved a little bit earlier up within that whole battery of tests, but we're just looking for their range of motion. So if we can palpate or kind of feel along the spine and automatically note a lot of tenderness or a lot of pain, we're not then going to say, okay, let's move it around side to side. No, that's indicating that there might be some serious cervical spine issue or injury. We're basically just going to stop there, get them on a seat collar, get them in an ambulance, go into the hospital, things like that. So because of the severity of what this could indicate, it's been moved earlier on into the list. Part 6. Now this is our balance error scoring system. So our BEST test, or our modified BEST test, looking a little bit different. This is basically 6 separate trials of a test, 3 on a firm flat surface and 3 on a uneven, unsteady surface. So like an Airex pad or foam or something where it's going to be a little bit more difficult now to maintain your balance. We'll do this in 3 different stances. So feet together, like together, ankles touching each other together, hands on your hips, eyes closed. You're going to stand there and balance for 20 seconds. Each time you move out of that position and fall, your eyes open, your heels lift, anything from that list, you're counting the number of errors, right? So every time they get an error, they get a point. So a perfect score would be 0, meaning they have perfect balance, no errors at all. If they do several of these things all together, let's say they step, stumble, or fall, open their eyes, and their hand comes off their hips all at the same time, that only counts as 1 error. But we're doing this for a full 20 seconds with 3 individual stances. So feet together and then standing on your non-dominant foot. So how are we assessing what's their non-dominant? The easiest way to do that is if you were to kick a ball, which foot would you use? If I would use my right foot, now I'm going to do all my single leg testing on my left foot, right? We also have to think about previous ankle injury or anything that could cause them some issues in being able to stand on a single leg. So if they do have some type of injury, let's say on the side that you would be testing, in the short term, we can still go ahead and get this data, but do it on the other side. And then after now they have completed their rehab and have gained back all strength and stability, retest this on the on the non-dominant side, just so we have these again as some norms or on some baselines to look back on later on in the season. They need to have no shoes on because again, that affects stability, no ankle braces, no ankle taping, anything like that. The next stance we'll do is what's called a tandem stance or heel toe. So we'll stand heel toe again, first on a firm flat surface and then later on a foam surface. Hands on our hips, eyes closed for 20 seconds, just stand there and balance. With this tandem stance, we also want to make sure our non-dominant foot is in the back. So again, if I would kick with my right foot, I want my left foot in the back and my right foot to the front. So I would get scores for all of my firm flat surface and my foam surface. And then together that would give me some good data baseline. And then later on, if we did have to look at this stuff to help decide if an athlete needed to be returned to play, we could use this and say, well, your balance was perfect at the beginning of the season, so you're still having some deficits when it comes to balance if you've got a score of, let's say, 20 now after the fact. Now, some people also have really terrible balance, right? It's something that we should all probably train, but is pretty commonly neglected. So let's say that they just did terrible and they had more errors than they had good time throughout this test. The worst you can do in each category is a maximum score of 10 per category. So worst case scenario, they have a score of 60, right? So 10, 10, 10 for all three stances on the firm surface, and then 10, 10, 10 for the uneven surface. Now, this is going to be different though than if you opt to just not do the exam. So if you are just super concussed and have no balance kind of whatsoever, I'm not going to force you to complete this exam because then it's going to be dangerous, right? If you have no balance, you're going to be at a higher risk for falling anyway. So I'm not going to risk further injury by forcing you to complete this exam. I wouldn't necessarily just record a score of 60. Instead, I would write that this exam was not completed just due to balance deficits, right? Now, later on, it can still be added back in after they do get a little bit more of that control back, but we're not going to make them do this exam and risk falling and hurting themselves if we already know that they're pretty severely concussed, right? It doesn't give us any helpful information at that point. So there's no need to stress them out, embarrass them, and again, risk further injury. Part 7 is going to be some coordination stuff. So again, this can be arms completely extended, finger to nose, make it a little bit more difficult, close your eyes and extend your neck back. That's an easy way to measure some of this coordination. There are several other things that can be done to measure coordination, but this one's pretty simple. This might also be one of those field sobriety tests that police might perform. Looking at part 8, again, this is our standardized assessment of concussion, or SAC, delayed recall. So those same 5 words that we said earlier, repeat them back to me as many as you can in any order, right? So they've got some time to be able to complete this. If they can't name them all, that's fine. Again, we're not telling them throughout the exam that they need to remember these. It's just, oh, hey, by the way, tell me as many as you can. So it's that same exact word list from before. Now, when you read them initially, it was the rate at 1 word per second. So you're not blurting them out as fast as you can. You need to make it something that the athlete can actually achieve and succeed in. So enunciate clearly, 1 word per second. Again, if you're making your own word list, completely unrelated, 2-syllable words. Now, when we're moving into our return to play protocol, there are some differences that each school might decide to add into their concussion return to play protocol. There are some guidelines that the NCAA has. There are some guidelines that CASA, so the State Secondary School Association, might have. But in a most general sense, there's a couple of things that need to happen. One, the athlete needs to be symptom and medication free before we're starting our return to play criteria. Now, this isn't stopping their daily multivitamin, their Zyrtec, their birth control pill that they take every day. It's not that. It's the medications that they take for the symptoms that they had. So if they have a headache and they've taken Tylenol for the past couple of days, well, you still have symptoms. It's just being masked by that Tylenol. So I want you to not have a headache and not be taking Tylenol for those headaches before you start this return to play criteria. Let's say maybe they have some nausea, so they've been taking some Tums or some meds to control that. Again, that's still a symptom. You might be symptom-free because the medication is controlling that, but you're not really symptom-free if you're taking medication for those symptoms. So symptom-free, medication-free before we start this return to play process. Now, regardless of the level, there are, again, some similarities that it has to have. So, it has to be a stepwise protocol. So you're not going from 0 to hero overnight, right? It'll take a couple days to get this back, especially in the educational realm. So college, high school, or even some younger levels, we need to make sure that they have return to learn in the classroom before they start their return to play criteria.